All right. Today I'm going to be doing a slideshow voiceover lecture on assessment tools and research. A lot of the terminology related to statistics that we see when using standardized assessments in OT. Um, I decided to do a voiceover lecture for this case because I actually just had a graduate student tell me how she remembered this lecture and how helpful it was for her to go back and to listen to some of the terminology that was used and to kind of corroborate in her readings and to honestly pause it and get up and move around and then come back to it when she was ready. And so sometimes I don't always get positive student feedback on voiceovers, but I thought about it and I thought that with some of these terms it would be a good thing to do. So basically all this lecture is trying to define terminology that's related to statistical analysis that we're going to see in assessment tools. And this is going to be important for your assignment where you critique assessment tools. Also, I want you guys to identify the threats to validity and reliability of using your assessments and of using your testing results, and describe ethical considerations for whether we're working in early intervention. Intervention is when you work in the client's home and the child is between the ages of 0 to 3. When you do that assessment, you are looking at that given situation in their home at that given time. Okay, same thing with outpatient. Outpatient therapy can be a little bit more structured and more of a sterile environment because we have less distractions in an outpatient clinic than in a real life setting. So we're looking at that information about how that person is performing in that type of situation. The same thing with school-based therapy. You'll do your evaluation or your assessment piece within the school because you'll be looking at that specific situation in the school. Okay, so again, if I were you, I would jot down that the purpose of assessments include looking at early intervention, outpatient therapy, and at school. Okay, so the purpose is to look at your particular client or subject in their given situation. And again, the three common areas are going to be early intervention, outpatient, and school-based therapy. So why do we assess? What are the results used for? Well, we can take a look at our assessment results and from there decide if maybe another assessment is necessary. Maybe another discipline is necessary. Maybe we need to refer to physical therapy or speech therapy or audiology or dietary or social work. I mean, the list goes on and on. Also, if another assessment is necessary, say we use an assessment tool that has a variety of different areas to assess, like fine motor skills, visual motor skills, gross motor coordination, those sorts of things. So as we do that assessment, we find out that the child's great in gross motor, the child's great in fine motor, but the child is really, really poor with visual motor. And so then there are a number of visual motor assessments, and so our initial assessment could guide us and tell us that maybe we need a more in-depth assessment with just specifically visual motor skills. The next reason why we assess, and not to get confused with allowing occupational therapists to diagnose, because we do not diagnose, but the use of assessments can help aid in that diagnosis process. So particularly I'm thinking of the diagnosis of autism. Okay, there's not a blood test that you can run for autism. There isn't any specific markers or anything like that to confirm the diagnosis of autism. Instead, they diagnose that by looking at specific traits or behaviors within that child. And so there are certain types of assessment tools out there that OTs can give or be a part of that measure these specific traits or measure these specific behaviors. So if this child scores really, really, really low in a particular area, and we share that with their pediatrician, it may help the pediatrician decide whether or not to diagnose that child with autism. Also, some of the assessment tools help predict future performance in certain areas, which is kind of interesting when you start looking at the reliability and the validity. Sometimes they'll look at they'll compare one assessment tool with another assessment tool in order to sort of predict how that child would do in that particular assessment. So again, it can help aid in diagnosing somebody, but although as OTs we personally do not diagnose. The big reason that I used assessment was to determine the eligibility for services, as well as to develop intervention plans and to evaluate overall progress. So some cases in early intervention, I know they need to have a certain percentage of delay, right? They have to be, I think, 50% delayed with one particular area, or 25% delay in two areas. So they may have a 50% delay in fine motor skills, and that would qualify them for early intervention. Or maybe they have a 25% delay in fine motor and a 25% delay in speech and language. So then that child would be eligible for early intervention services. For outpatient services, I have to say North Dakota has been pretty good, to me anyways, about when I use a standardized assessment. They haven't come back and specifically said, oh, this child is not 2 standard deviations below the mean, so they're not going to qualify for services. As long as I have said, okay, this child has a slight delay in fine motor skills, but it's really impacting his functional ability to use utensils. Okay, so if I tied that function piece to a slight delay, it didn't matter how much delay that was, they still allowed me to see the child. I've worked with OTs who have worked in other states and in other programs, and they have to have like 2 standard deviations below the mean, or 1.5 standard deviations below the mean in order for them to qualify for services in some outpatient settings. So again, that's going to depend on what facility you work in, what state you work in, that sort of thing. Another reason why I use standardized assessments is to help develop intervention plans. So if I give the Peabody Developmental Motor Scales and I'm looking at fine motor, I'm looking at visual motor integration, in my head as an OT, I can say, okay, well, if they're delayed in this area of fine motor skills, I bet they're going to have problems with some occupations with getting themselves dressed and manipulating eating utensils and dressing fasteners and those sorts of things. So those assessments help me develop my intervention plan. Also, they help me evaluate overall progress in therapy. So I'll do an initial evaluation and say I do the Peabody Developmental Motor Scales, and then their insurance is due in, say, about 6 months for the reauthorization, cut to OTH 415, right, when we talked about reevaluations and documentation, that sort of thing. So I may pull out the Peabody again in, say, 6 months, reevaluate that child and see if we've made progress, see if they've improved. And so I can compare my initial data of my initial evaluation with my evaluation I completed 6 months later, and I can highlight the progress that's been made based on my interventions. The other part or other way to use assessments is for research. So you might do a pre and post test survey design, Or research design, where you're implementing a certain assessment tool, you're doing a certain type of intervention, and then you're reassessing with that same intervention. And again, you're comparing that initial data. And that initial data can be used to justify, or that data, that measurement and progress can be used to justify and make an argument of how wonderful your intervention is in research. So this should be pretty much a review, I think. The types of data that we collect, or the different types of methods, is by doing some sort of a health history. Okay, by getting an occupational history of the child or of the parent or of the client. Maybe doing some sort of survey. Okay, I know some of these standardized assessment tools out there are survey. Looking at some sort of an experimental types of data collection. We don't do a lot of experimental types of data collection in OT. It's mostly history, survey, observation. But say you're working, I think of chemistry, right? Where you add one chemical to another and then this happens. And so you make note of that, right? It's some sort of an experimental data collection design. Again, as OTs, I think more commonly we look at histories, surveys, observations. We get the history, the health history, the occupational history by a lot of times doing a questionnaire or some sort of an interview. Sometimes we take measurements, okay, active range of motion, grip strength, pinch strength, passive range of motion. There's also ecological types of data collection. And with ecological, they're just looking at, you have naturalistic, which occurs in the person's natural environment. So what's going on in school? You are going to assess and take your measurements or do your questionnaire in school to find out what's going on in that particular environment. So, naturalistic, again, you're taking a look at the child's environment that's specific to them. An example of that is called an arena evaluation. Okay, so under ecological, you're recording physical, social, psychological features of the child, overall development, that sort of thing. You're doing it in their natural environment. This screams early intervention to me, okay? So then you have your arena evaluation. And again, your early intervention, it takes place in the child's natural environment. And it takes place with a multidisciplinary team doing a variety of assessments and all looking at, all completing observations. So that arena evaluation is like an arena. The child sits in the middle or the center of the room. You might have physical therapy, occupational therapy, and speech therapy, and early education, and they're all there sort of tag teaming the child, doing their types of assessments while somebody's interviewing the parent, while somebody's giving the parent a questionnaire, and then they all come back together and they write up a treatment plan based on everything that was done. And then they appoint an early interventionist, just one discipline, to carry out all of the goals. So looking specifically at measurements and assessment tools, they can be norm referenced. Norm referenced particularly compares your child that you assessed and compares them to the rest of the world. Okay, so a lot of times in the norm referenced assessments, you're making a comparison. You are comparing your child to another set of children that the assessment used to come up with their baseline. Okay, and you're using your results of your child and you're comparing them to other children. Now, when people come up with their assessments, okay, and they are they're making their assessments, they're publishing them, and they're going to test them before they publish them. They get what's called, quote, the norm. Okay, the normative sample is what they call it, the normative sample. So they take a sampling of children. Say we're just going to work with children. They're taking a sampling of children. Okay, they're going to try and get that sampling to represent the entire world or the entire United States. Okay, they're going to try. They're not going to be perfect, and they will explain that in your assessment tool. But then when you complete your assessment on a child, you are looking at, okay, what age is my child? What score did they get? Now, what did a typical child score for their age? And then you compare that, okay? Criterion referenced assessments don't compare the child to that normative sample, to the rest of the world. Criterion referenced assessments just take a look at, well, this is what a typical 2-year-old should do. A 2-year-old should be able to walk upstairs. A 2-year-old should be able to take their socks off and to pull up their pants and to pull their shirt on. And so then if you're giving a criterion referenced assessment, you are assessing your 2-year-old child. Can they do these tasks? Can they not do these tasks? Okay, or these are what tasks a 2.5-year-old should be able to do. But there is no comparison to that normative sample, okay, that perfect world. Informal assessments are also used, and again, they're not compared to anybody. There's no set guidelines that they have to follow or meet, as in criterion referenced assessments. Informal assessments may just be a questionnaire, or you're getting the point of view from maybe the caregiver or the teacher. It's more informal. Looking specifically at norm referenced assessments, they can be standardized, which standardized assessments follow specific formal measures, okay? And these are the ones that, since there's that normative sample, that sampling of children where they handpicked these typical children, or so they thought they were typical, to represent the whole wide world or the whole United States or whole Australia, wherever, they are giving specific instructions to those children for completing these assessments. So, if you are going to complete an assessment on a child, and you are going to use that score to qualify them for services, so in other words, you want to compare them to that normative sample, that means that you have to give the same exact instructions to your child that you're assessing in order to compare their results with the typical children's results. Okay, so using standardized assessments, they provide scores that can be compared to the normative sample for that population. Okay. Again, you follow exact uniform procedures for administering the assessment and for scoring. So again, you're going to see in these standardized norm referenced assessments, you will be told exactly what you need to say, because when they got that normative sample, that is the exact terminology, the exact procedure that they used when coming up with that sampling. Okay, and so if you're going to compare your child to that sampling, you have to follow the same procedures. Items may not have functional significance in your assessments, but give indicators of that child's ability level within that domain. And so I'm thinking of norm referenced assessment tool. I'm thinking of like the Peabody developmental motor scales. Okay, on one of the items in there, on one of the indicators, it has the child touch their thumb to their finger so many times. Okay, within so much time. Touching your fingers within 5 seconds or 10 seconds is not functional, right? But it still gives an indicator of the child's ability level within that fine motor domain. because touching your thumb to your fingers tells us about thumb opposition, and it tells us about finger isolation. And those are huge indicators in the fine motor domain. Okay, so again, touching your fingers within 5 seconds may not have functional significance, but it is an indicator of fine motor skills. Typically your norm reference, your straight up norm referenced assessments are not intended to use or develop goals or intervention plans. Now what this says, what this means, is every single item on the Peabody, which is a norm reference and its criterion reference assessment. It's a gray one, but I'm just going to use it because we're going to talk about it soon. Norm referenced, so on the Peabody, you have the child stack blocks, so many blocks. Okay, you have the child snip on paper with a scissors. You have the child bead little tiny beads. You have the child touch their thumb with their fingers within so many seconds. Okay, you have them do a lacing strip. So my goals aren't going to be to complete a lacing strip. My goal will not be to touch my thumb to my fingers within 3 seconds. Okay, I cannot take those specific indicators in that assessment tool and develop goals from there. Okay, now, is block stacking part of play? Yes, and so I guess in my practice, I did have some items directly off the Peabody, but I thought there was more function to them. Okay, cutting out simple shapes, that is functional. Okay, but making snips with the scissors, which is the part on the Peabody, may not necessarily be functional, but I can make that functional using my OT mind, based on that specific indicator that's being measured on that assessment tool. The primary purpose for standardization and standardizing that assessment is to make sure that it's reliable and that it's a valid assessment. So every other therapist that gives that assessment tool is going to find the same things. Okay, that it's really measuring what it says it's measuring. Typically, to identify a norm-referenced assessment, you will see scores such as standard deviation. What is the standard score? A scaled score, T-score, or percentile rank. So if you see some of those scores being reported in your assessments, your standard deviation is how many deviations below the mean it is compared to that normative sample. Okay? Or that percentile rank. What percentage does your child fit into based on that normative sample? So again, there's that comparison. Now, criterion referenced assessments only compare the child's performance just to that particular criterion. So, looking at the Peabody Evaluation of Disability Inventory, again, we're going to be going over that soon. The criterion is self-care. Okay, one of the criterion that it measures is self-care. It's basically a checklist that says, is the child able to do this, or is the child unable to do this? Okay, so it provides data on what skills they can do and what skills they can't. So that can tell me exactly, in my own head, I know that a 2-year-old should be able to take off their pants and take off their shirt. So when I look at the Peabody, or the PDMS, or the PD, too many P's, the PD, if I look at the PD, and I go down every single one of these skills that are on the self-care criteria, I can say, oh, they marked unable for dressing or undressing, and 2-year-olds should be able to undress themselves. That's an area we can work on, and that's functional. So again, these procedures may or may not be standardized, meaning there are specific standardized protocols to follow when administering them. But what I really like about criterion referenced is that there is a more direct relationship to functional skills. Okay, so it can be used to focus your intervention. Also, and this is kind of the, gray area that's confusing, criterion referenced assessments can also be norm referenced. Okay, so the Peabody is an example where it is norm referenced, but there's also some criterion in there. A 4-year-old child should be able to touch their thumb to their fingers within so many seconds. Okay, that's not exactly a functional skill that's needed. Okay, but that is something that measures fine motor, and it is something that they were able to norm reference that or to compare that. Where the Peabody is norm referenced, or where it is more criterion, where you can make those direct functional skills with, like I said, block stacking, or with drawing simple shapes, or cutting out shapes. Okay, those are direct functional skills that help make the Peabody also criterion referenced. I hope that makes sense. And hopefully as we go through the Peabody and the PD and we practice with those, that'll make more sense. Informal assessments include non-standardized assessments. So again, there's no particular protocol that you need to follow. They do include some skilled observations. So you may have some checklists of the setting, what behaviors you're seeing, what's the quality of movement, the frequency or duration of the movement as well, or the activity or the task or the occupation. Also, informal assessments can be interviewing, okay? Because you're getting it from one perspective. You're getting it from the client, or you're getting it from the parent or the teacher. Okay, so you can have an outline of data to collect, or an outline of things to interview. You can have a questionnaire while you're interviewing, which a lot of times you get really good data if you ask open-ended questions like, describe a typical day. What are your roles? What do you typically do when you get up in the morning? Those are all open-ended questions, as opposed to, do you brush your teeth? Do you comb your hair? Those are more yes or no, more closed-ended questions. So what do we do? How do we decide what assessment tool to use? Basically, we need to find a specific purpose or identify a specific measurement or a specific area that we want measured by the assessment or by the test. Was the tool designed for your client's age and abilities? So every time we go over an assessment, we're going to be looking at what age that assessment is used for. What are the psychometric properties? Okay, what is the validity? What is the reliability? What is the normative data pulled from? Okay, some of the assessments, they pull from lower socioeconomic status. And so if you are working in the Washington, D.C., up on Capitol Hill in their daycare in the White House, where people have higher socioeconomic statuses, you may not want to use that assessment tool in that type of setting. Also, the pragmatics. What's the length of time of your assessment? Okay. If you only have 50 minutes or 60 minutes to give an assessment, are you going to take something that's going to take 5 hours? Okay. What is your competency in administering it? Okay. As new graduates, you will not be administering the sensory integration praxis test. Okay. You're not competent in administering that. You need additional training. Also, what is the cost of the assessment, and do you have the space for it? I know we had issues, physical therapy had issues because they needed, in our clinic, because they needed a certain length of time or a certain space, a certain length for children to run. And we did not have that open space for them to run so many feet for them to complete that assessment. So that wasn't a good assessment tool for them. Or they could only do it in the summer when they could go outside and use the sidewalk. All right, so looking at using normative criterion reference assessments, we're going to see some terminology that's related to statistics, okay? If you haven't done so already, your Mulligan Chapter 4 and your K-Smith Chapter 6 goes through all of these in greater detail. They give examples, those sorts of things. So please review, please go through go through and review those in greater detail within those readings. They're really quite good. So a lot of times we use descriptive statistics, okay, when we're doing an evaluation. Is it a boy? Is it a girl? What age are they? What is their family makeup? What are their roles? What are their occupations? Those can all be considered descriptive statistics because they provide information about the characteristics of a group that we're looking at or our clients. Okay. Variability looks at how far away our client deviates from the mean. So again, looking at variability, you're looking at the group and how far it deviates from the mean. The mean is sort of the average, right? The average, the middle ground. Not to be confused with the median. I'm just when I get to the bell curve, I'll show you what I mean here. But the mean is sort of the average, okay, where that's going to go. So again, with normative standardized assessments, we're comparing our child that we assessed, we're comparing them to the normative standard group. And so we want to measure how far away from that average group did they lie. So by measuring that, you'll hear the term standard deviation. You'll hear the term z-score or variance. Okay, so when you hear the term standardized or standard deviation, it's just how far away from the mean they are. They can be lower than the mean. They can be higher than the mean. Okay, the z-score is just another word for standard deviation. It is, I swear, standard deviation is the same thing as a z-score. It is just measuring how far away from the mean the child is. Okay, so if you have a z-score of 1.5, okay, so my z-score is 1.5. That means that I am 1.5 standard deviations below or above the mean. Okay, if it's negative 1.5 z-score, that means I'm 1.5 standard deviations below the mean. Okay, or if I'm 1.5 standard deviations, that means that I'm 1.5, or a z-score of positive 1.5, I'm 1.5 standard deviations above the mean. So percentile rank is another measurement, right? It's another comparison where we're comparing our child and how they rank with the normative sample. Okay, and so sometimes students have a difficult time, to be honest, I have a difficult time wording percentile rank when I'm trying to explain it. And so I always read this from the Mulligan on page 198 in your Mulligan text regarding percentile scores. So percentile scores look at the percentage of people in that normative sample who scored at or below a given score. Okay, so at or below a given score. For example, say a child had a score of, and again, I'm pulling this right from Mulligan page 198. If a child has a score of 15, and when we look at the bell curve, or when we convert our numbers, which all of our standardized assessments have beautiful charts, we don't have to do math, we just have to look at the numbers and make sure we're looking at the right chart. It will tell us that a score of 15 is the 38th percentile. Okay, that means that 38% of the children whom he or she is compared scored at or below this score. Okay, so again, When we get a score of 15, we look at a chart and the assessment says, okay, the score of 15 means that the child is in the 38th percentile. Okay, that means that that normative sample, because that's who we're comparing to, right? 38% of the children that were tested in that normative sample fell either at or below this score. So what I want you to take away with the percentile rank is this. If you're doing an assessment tool and it calls for percentile rank, refer to page 198 in your mulligan so you know how to write it up. That's supposed to be kind of funny. Because again, it's word for word. The other piece that I really want you to take away is when you see percentile rank, you're comparing your child again and where they fell in that percentile compared to that normative sample. Okay, so that's the big thing that I want you to take away from percentile ranks. Age equivalent scores are also used, and again, they're taking that score from that standardized test, say a score of 15, and you look at the chart, and it may give you an age equivalence of everybody who is 2 years, 0 months of age. If they score a 15, or everybody who scores a 15 on the standardized assessment, the age equivalence is actually 1 year, 6 months. Okay, so again, you're looking at your score on your assessment tool, and you may get an age equivalent score. Now, I know some facilities do not use age equivalent scores at all because they sometimes scare off parents. Because if you're sharing with parents, oh, your 8-year-old daughter just scored an age equivalence of 2 years and 8 months on fine motor skills. So basically you're telling this parent that their child is functioning at a 2-year-old. And so that can kind of upset parents, and they don't always hear that, no, that's fine motor skills. They don't always hear that. And so if you do use age equivalents, just be very cautious with them. Sometimes I wouldn't even show age equivalents to my parents, but I would refer to it for insurance companies. So again, that I know Dr. Olson didn't use that in the school system because it was sometimes disheartening and misleading with overall function. Okay, so just kind of use caution with that one and see what your fieldwork sites do. Looking at other statistical terminology, you'll hear the terms correlation, and that's the relationship between two variables. Okay, so you may see a correlation in some of your assessment tools. Is there a correlation between fine motor and visual motor skills? So in some of the assessment tools, like maybe the Peabody, the BOT2, you may see some correlation scores. So some of the different performance components that are in those assessments may help predict or may have some sort of relationship where if they have great fine motor skills, they have great visual motor skills. And that's not always the case, but you may see some of that with some of your domains in your assessments. A correlation coefficient gives the strength of that correlation. So if you're reading up and there's correlation and then you see these random numbers, okay, they should be numbers that range from -1 to +1.0 or +1. A 0 indicates that there is no relationship. So the closer to 0 it is, the less likely there is a relationship. So if it's a -1, that means there's a negative correlation. So as 1 goes down, so as your gross motor skills decrease and get worse, you have higher fine motor skills. And again, that's not the case, but just if one goes down, one domain goes down in function, the other one goes up, that's a relationship. That would be a negative correlation. Where a positive correlation, I think of height and weight. Okay, the taller you get, the more you weigh, right? Not always, of course, but again, there is a positive correlation that is associated with height and weight. Again, 1 and -1 are the extremes, but you have an infinite amount of numbers between -1 and 1, and so your correlation coefficient might be -5 or -0.52. So there's some kind of a relationship there, but it's not a super strong relationship because it's somewhere between 0 and -1. So you may see some of those random numbers. What I usually tell students is, let's see here. What I usually tell students is that anything that is 0.7, whether it's -0.7 or positive 0.7, is a pretty strong relationship. So those would be pretty cool. Not that they matter in an assessment so much, because sometimes we don't care for them to relate to each other. If we're assessing fine motor and gross motor, I really don't care if there's a relationship. They're two separate things. Also, reliability and validity, we are going to take a much closer look at in the next few slides. And then that standard error of measurement is also a score that we may see, also known as the SEM score. And that's, again, we'll go over that when we go over, I think the PD goes over the standard error of measurement. That's basically just used to estimate if there could be a potential error with testing. So if we were to give the same assessment over and over and over and over again to the same child, there would be a level of fatigue or boredom or attention issues. And so that standard error of measurement just gives us a range. Instead of a standard score of 15, it would say the standard error of measurement is plus and minus 3. Meaning that if we were to give the assessment maybe when the child didn't feel well, or maybe the child was hungry, or there's some sort of reason, they could get either 3 above that 15 or 3 below that standard score of 15. So then their standard error of measurement would be 12 to 18. Okay, because if your SEM score is positive or -3, you just subtract and add 3 to your standard score, and then you get a range of scores. So if you were to, and then you have some kind times a confidence interval too, and that confidence interval tells you you're 95% confident that if you were to give this assessment again to the same child, you would still fall within this range of scores. Okay, so that's kind of that standard error of measurement. Moving on to, again, we're going to get to reliability and validity. But this is that normal distribution. Okay, we have that beautiful bell curve. The X is the mean. Okay, mean is, there's another word for mean, is average. And so every time there's a standardized assessment, they have that sampling of children. Okay, they always have, in a regular sample of children, you have some outliers here. So you have those that do really, really, really well. You have those that do slightly above average. You have those that are right average, slightly below average, and then some outliers here that do fairly poor. Okay, not very many though. Okay, the majority of them are here because that's average. So, and that's why it's the bell curve is bulging here, because the more participants, most of the participants are going to score somewhere around this line. So if we're looking at standard deviations from the mean, okay, so this is the mean right here. Okay, right in the middle, we have, I'm going to jump to cumulative percentage right here. So 50% of the people, the normative sample, should score here because that's the average. Okay, so if somebody scores a 50th percentile rank, they are right at average. Okay, that's a cumulative percentage. So a lot of times, like say on the PDMS, the Peabody Developmental Motor Scales, the average score that you can get is 100. So if you score a 100 on your area in the Peabody, on the fine motor skills on the Peabody, you are going to be in the 50th percentile. Okay. Now if you scored an 85 on the Peabody, okay, so right here 85, that's 15 points below, okay, 15. That is considered 1 standard deviation below the mean. This little sign here is standard deviation, okay. You'll notice that the z-score is negative 1.0. It's the same thing as the standard deviation. So some assessment tools, you will figure out a z-score. And that z-score, all that means is how far below or above the standard deviation they are. Okay? So say you score, say your z-score is negative 1.5, okay, on the Peabody. Your z-score is 1.5. I say that because there are some places where you work where you have to have a z-score of negative 1.5, or you have to be 1.5 standard deviations below the mean. And so you'd be right around in here between negative 1 and negative 2, and negative 1 and negative 2 standard deviations right here. Some places I know worked, where I know some therapists worked, they needed to be 2 standard deviations below the mean. Okay, so that would be if you had a standard score of 70 on an area of the Peabody, excuse me, you would be at a z-score of negative 2, which would be your 2 standard deviations below the mean. What's really interesting about this is you look at several types of standardized assessments, like IQs, a lot of psychological tests, many of your OT standardized tests. They convert their raw score, or they convert their score to this standardized thing here. So if you have, on some of the psychological testing, if you get a score of 100, that means that you are at the mean. You are at 50%. You are good. Okay? Minus 15 is 1 standard deviation. So if you get an 85, you're 1 standard deviation below the mean. If you get a 70, that's 30 points. That's automatically 2 standard deviations below the mean. So there are some assessments that deviate, that do not have this, where 100 is the mean. Sometimes they're 50. There's some assessments where 100 is the mean, but it's plus or minus 16 and not 15. So those are things that you're really going to want to look at on your assessments that you're giving, your norm referenced assessments. Okay, and do they need a z-score? Are you able to convert a z-score by looking at the charts? That sort of thing. Okay, getting to reliability. Reliability coefficient, it's a number. Again, it should be 0.7 or higher, all the way up to 1. And you won't ever see a 1. I have seen some 0.9s before and some 0.98s, I think. But it's the degree or consistency where your scores are obtained when one individual tested on 2 different occasions with different items or under different conditions. So basically, what that is meaning is how reliable is the data that you're getting. So ways of determining reliability, and a lot of them you'll see, is test retest. So the same therapist gives the assessment to a child, and then over time the same person gives the same assessment. So you're doing a test, and then you're giving that same test again a little later. Okay, and if you get similar scores on a typically developing child, you should have some sort of retest reliability. Inter-rater is when there's two independent raters, so two different therapists, and they're giving the same scores simultaneously. So you may have, this is a good thing for you guys to do on fieldwork, is have your fieldwork educator score up an assessment and then you score up an assessment. So you're two independent raters, but you're still assessing the same thing, and then you compare. Reliability means that you should be getting a very similar or consistent score when doing that, and that's your inter-rater reliability. Again, we have that SEM score. Again, that's based on reliability and validity. Looking at, when I say theoretical construct, I mean like fine motor domain or gross motor domain, self-care domain. So it's the number of points above or below that's tested of what that patient's real score is most likely within. So again, if you have, hypothetically, if you were going to give an assessment to a child and they were really, really good one day, and then hypothetically you were going to give it again, but they had a headache, okay, your SEM score may be 3. And so your standardized score is 75, and so then you would plus or minus that 3 from 75, and so then your range would be 72 to 78. And then your how many percent confident, 90%, 85%, 95%, these are all in charts in your assessments that you're going over. Okay, they're all in charts. How confident are you that if you were to give this assessment on another day, that child would still fall within that range? Okay, and then that 98 or 95% would be that confidence interval. Okay, I know that's a little confusing right now because it's new, but we look at confidence intervals with the Pediatric Evaluation of Disability Inventory, and it should make more sense then. Now, validity is a correlation of the test based on what it's measuring. Okay, so sometimes you'll refer to 0.4 to 0.8, which is a Cronbach's alpha, which I don't expect any of you to know. But if you're looking at validity and you see some terms like face validity of 0.7, content validity of 0.8, those are things, if they're above 0.7 or greater, it means that they're relatively good. So, you know, what's the face validity? So what does it actually say that it's measuring, and what extent does it measure it? Okay, if your face validity, if you're looking at an assessment and it says that it measures fine motor skills, but it only has one fine motor task on there, I bet its face validity would be pretty poor. Okay, content validity is, do the items accurately sample the domain? So content in the P-body, does all the fine motor items in the P-body actually measure or accurately measure fine motor skills? Criterion validity often predict performance in other measures. So if they score really, really high in fine motor, do they score really, really high in gross motor? Okay, again, that criterion validity, some assessment tools, not every assessment tool is going to have every type of reliability or validity. Okay, criterion validity, I don't see that very often, to be honest with you, with assessment tools, and if I do, it's usually really low because we don't expect there to be a relationship between fine motor and gross motor. Construct validity, how well does it measure the overall construct? How well does it measure activities of daily living? How well does it measure motor skills? Okay, the P-body developmental motor skills. How well does the P-body measure motor skills in general? Okay, so you may see some of those different types of validity reported in your assessments. Threats to reliability and validity. So again, if a child's not feeling well, they may not have a true score. They may not have a valid or reliable score. They may be ill. But remember that the purpose of doing a standardized assessment is to get a measurement based on that child's performance in that particular instance. Okay? So fatigue, if the child's fatigued. If they're unfamiliar with the examiner or the test environment. Okay? If the length of the test spans over a length of time. If there's muscle tone differences, it may affect speed and accuracy of how they do things. And then cultural bias is one as well. So looking at the Peabody development or the pediatric evaluation of disability inventory, how well does a child use a spoon and fork? Well, again, if you are raised somewhere where they use chopsticks, you're going to score really low on that part of the assessment, and culturally, it's going to bias that assessment. Becoming a competent tester. In Case Smith, page 185. Study the test manual. Look at the test. Read the test manual. Read it. Observe the test being administered by somebody else and talk about it. So this is your opportunity on fieldwork. This is your opportunity in practice lab. Okay? Practice the test administration. Practice lab. Do inter-rater reliability with an experienced examiner. Practice lab. Or on fieldwork. Okay? Prepare the administration and the scoring cue sheets. If you want Colleen to make copies of anything, you guys can make copies of them. I can't. But if you're just going to practice and jot down things, practice writing on copies of the scoring sheets and going through the motions of looking up all the test charts. Prepare your testing environment. Administer the test items. Again, consult with experienced examiners about how you're interpreting the assessment. And then periodically recheck your inter-rater reliability. So maybe giving an assessment and then a little later giving it again. And how reliable are you? Ethical considerations. What is your competency? Again, you probably should not be giving the sensory integration praxis test right out of OT school. Okay, so what is your competency? The subject privacy, making sure that you're not giving your assessments in front of everybody, because you want your participant to have privacy. And with healthcare, there's HIPAA, there's all that kind of stuff. Who do you communicate the test results to? Is it physicians? Do we have releases signed if you want to get your test results, or if your school wants to get your test results and you're in an outpatient clinic? And then to be culturally competent, okay? Knowing what the culture is of the client. What is the bias of the test? Okay, there's, I think, some tests, they are primarily with African American children. Is that a bias of it? That's something that you're going to have to decide as a therapist. The language of the test. Okay, some of the assessments are published in French, some of them are published in Spanish. Is there an interpreter needed? Again, if you're doing that though, and you are doing a standardized test, you need to follow that standardized protocol. Sometimes that can, using an interpreter, can deviate off of that standardized protocol. And to a point, if that happens to you, that's okay. That happens. Just document it and make note that, hey, I deviated from my standardization protocol. Therefore, I was unable to compare my child to the normative sample because the child that I assessed was not given the same instructions. Okay, so I hope you can rewind that and listen to that again, because that's something that's really common, especially for people who are just starting out and doing assessments.